Now I'll ask the vascular team to come on, and we'll just go through our surgeons real quick to introduce themselves. Dr. Coleman.
Hi everybody. It's great to be here, and this has been so fun to watch play out so far. My name is Dawn Coleman. I'm a vascular surgeon at the University of Michigan. From an educational perspective, I serve presently as the program director of both our integrated residency program and the independent vascular surgery fellowship. I'm also a counselor for our Association of Program Directors in Vascular Surgery. I trained at Michigan. I did my general surgery training. I stayed for a fellowship. I've been really, really lucky. I love what I do. I consider myself to be a busy clinical vascular surgeon, and I have a really great practice that I cherish. In part, some of that is to care for children who've got a rare developmental disease that affects their aorta and their renal arteries. But I also operate on a fair number of adult patients with kind of complex aorto and mesenteric pathology. And so this job's great. So excited that you're dialing in to learn more about it and learn from these amazing panelists that I get to talk alongside tonight. And we're happy we're here and excited to do this.
Great, thank you. Dr. Hingorani.
Hi, my name is Neil Hingorani. I'm a vascular surgeon here in Brooklyn, New York. I had done my medical school up in Albany, Albany Med, in upstate New York, and then I ended up doing my general surgery residency here at St. Luke's Roosevelt, as part of the Columbia system here in New York City. And then I ended up doing my fellowship here at Maimonides Medical Center in Brooklyn, New York. I finished in 1998, and I've been working here in South Brooklyn ever since. We are also involved with our general surgery residents, our fellows, and our medical students that we have. I presently work here at NYU Brooklyn, and I've been here for a couple of years. I wanted to highlight some of the stuff that that the others have mentioned in terms of one of the reasons why I think we are drawn to our fields are the mentors, and we're always serving as mentors to others. So I think that's one of the reasons that inspire us working with our mentees.
Great. And Dr. Stone.
Thank you so much for the opportunity. I'm Patrick Stone. I'm the program director at Vanderbilt University for the Vascular Surgery Fellowship. I did my general surgery in West Virginia, where I was born and raised, and stayed there. Actually, after a fellowship, went back to West Virginia, where the current president of the SVS, or the Society of Vascular Surgery, was a great mentor. During my general surgery, Ali Abarama steered me through all the clinical research that I was able to do in my first 10 years of practice. And mentorship probably is the most important thing, as you've heard from the other panelists. Vanderbilt is a great institution. Nashville is a great city, and I had the great opportunity to be here and work with the general surgery residents, as well as help train the vascular surgery fellows. I picked vascular surgery because of the variety. I tell all the students who come to rotate with us, like today, I'm doing a temporal artery biopsy, then taking out a carotid body tumor, then doing some varicose veins, then doing emergency acute limb ischemia. And so we work from head to toe and do a lot of emergencies, a lot of elective cases, and we get a tour around the entire body. So that's what drew me to vascular surgery.
Great. Well, thank you. So maybe similar to the cardiac and thoracic surgeons, tell us a little bit about your work-life integration. Dawn?
Oh, I don't know that I have a lot to add that hasn't already been said. There were some comments that were made that I think really resonated with me. The comments that you can do it all, but you can't do it all the time, nor can you do it all the time really well. And so I'll just propose that my bias is that to thrive in a rigorous surgical specialty and to maintain any kind of integration that's really functional, I do think that you need to find yourself in an and a healthy culture with leadership that is supportive, working alongside partners that are accountable for each other. And so I've found that where I'm at, and I think that really the people make all the difference. I also have two little ones. I have a 3-year-old and I have a 9-year-old, and they're amazing. And I guess my thoughts for kind of optimizing what that looks like at home is, again, having support at home. So I have a husband who doesn't work outside of the house, which is a luxury. We overpay and outsource for things that allow us to optimize the time we have at home to be spent with the kids. And I have usually Zoom's kind of been hard, but normally I'm able to maintain pretty rigid boundaries that when I'm home, and my kids don't really see me working. And so if you commit to do something, definitely follow through because those words and those matter. And just think really carefully about how you want to prioritize yourself because there are a limited number of hours in the day. And what is important to you, because you really do have a lot of decision-making capacity and you are able to set boundaries. And so sometimes it's a matter of just being really honest with yourself, how you want to choose to outsource kind of your own resource of time.
I did that fatal thing. I muted myself. So Patrick and Anil, what do you do outside of work?
Go ahead, Anil.
Well, I do like to spend a lot of time with my family. I have 2 children. My children are 22 and 18 years old, especially riding the bike down by the beach. We're by the beach in Brooklyn. And spending time with my son and my daughter are probably some of the things that you cherish. Again, peaking focus on the family. I've been very, very blessed to have my wife, who is a stay-at-home mom. Even though she is a physician, she's been taking care of us for 18 years at home. And having that balance and having a very strong support system at home when you can't be there is actually what was mentioned in some of the prior talks. But I'd like to emphasize that again, that having that really strong person who can really make your life a lot easier and help with the kids, and vice versa, being able to help with the kids and spending quality time and making that a priority.
Patrick?
My kids are older, similar to Anil. They're finishing high school and one is in college. And I think the balance, it takes a long time to learn the balance of work and then scheduling so that you're able to spend as much time with your family as possible. I tell the fellows, when you schedule cases in a way that your daughter's got a recital that night, you don't want to schedule an aorta biofilm, or you don't want to schedule something if you know ahead of time that may be problematic. You want to do some low risk cases and you want to schedule very light that day and short. And then it takes a while to understand you can actually do that. And I think it's a skill that it needs to be learned or taught earlier in our careers. It's taken me over 10 years to figure how to do that. Outside of work, I love hunting. I love exercising, and I'm an avid CrossFitter for almost 15 years. And so I'm still one of the dinosaurs in that without a broken back or some major injury.
Great. There's a couple of questions about training against a similar the cardiothoracic paradigm. So, first, what turned you on about vascular? What are some exciting things right now? And, obviously there's 2 main training paradigms, going through general surgery and doing the I6. And so what are some comments about that? I'll start with Dawn again.
Those are great questions. Well, I was drawn to vascular surgery. I was planning to be a transplant surgeon. And then as a general surgery resident, halfway through my training, I had the opportunity to scrub with Peter Henke, who's amazing, my new division chief. And he took me through as a first assist 2 open aortic cases in a month. And that was kind of all it took. And I went home and I told my now husband, who at the time was my fiance, that I had to operate on the aorta kind of with enduring longevity to be happy in life professionally. And so it was a very quick kind of aha moment and transition for me. And I think a lot of the things that were referenced with the cardiothoracic panelists, I think we would echo. I will say that our patients are complicated and sometimes simple. And so there's just a tremendous amount of diversity in the pathology and the diseases that we're treating. And what is really exciting about our specialty is just the rate of innovation that's occurring with treatment options for patients, which just continue to kind of evolve in real time. And so I'm about 10 years out from my fellowship training, and it's a very different practice than it was when I was kind of elbow deep in that process of learning. And I watch the current generation train, and they learn differently, and they're training differently than I did, and they are coming up with a skill set, frankly, that's better than mine in a few very specific domains, and I really love that. I think we have a huge armamentarium to help our patients, and that matters. And then I think most of us kind of really pride ourselves in the ability to do hard things. So we respond to a lot of kind of surgical crises. And some of the things that probably cause us to lose a little bit of sleep or spend time away from our family, we really do, I think, appreciate the opportunity to have that impact on patients at a really direct and local level. And so as far as kind of what's coming through with surgical education that is going to be really fun, I think it's the kind of rise of innovative educational techniques that probably echo some of the technology that our learners are exposed to, and also echo what's rising through general surgery. So I don't want to keep talking. I'll pause myself and let the others also kind of field a bit. But I think it's an exciting time to be a vascular surgeon.
Neil?
I'd like to echo some of the comments that Dr. Coleman had made. And Dr. Stone had made, that the diversity in vascular surgery is tremendous. You're operating from the head to the toe, quite frankly, except for in the heart and the cranium. The longitudinal development of relationships that you get with your patients is really quite fulfilling. I've had patients who I have seen since 1998. Since my first day out of fellowship. Those patients, if I do a bypass in one leg, the next most common operation they're going to have is some type of revascularization in the other leg. And that means I need to follow them for the rest of their lives, not only for the intervention that I make, but also for the further disease processes that they may present in other parts of the body, because these are all systemic diseases that we're dealing with. And while we do certain procedures, they're still not cured of their atherosclerotic occlusive disease. So following these patients has been extremely gratifying. I know some of these patients' families' kids, their grandkids, their uncles. I get to hear about their family trips. I get to really enjoy how they have changed over the last 20 years and how I have changed with them. The revolution taking place in vascular surgery is tremendous. And Dr. Coleman had mentioned some of this, that the pace of the new innovations is mind-boggling. I had struggled for 2 years during my fellowship to learn some new techniques with subvascular endoscopic perforated ligation. And by about my 20th case, I thought I got it down. I got the little nuances, the little tricks, and I could probably do it by myself. But by the time I finished my fellowship, that procedure was already outdated by less invasive, minimally invasive procedures with percutaneous techniques. The pace of innovation is tremendous, and it really keeps it exciting and challenging, and I think quite fulfilling.
And maybe, Patrick, I asked you a different way.
Yes.
I know you went through the traditional training. Should students who are interested strictly in vascular apply to the I-6? And much like cardiothoracic, if they on their CV they're very strong in vascular, what are some pointers that they have to apply for a general surgery program as well? Are there things they're missing if they go through an I-6 program?
Definitely. And Don could probably echo this. In Charleston, we had the integrated program and the fellowship, where I was with Ollie for 11 years. And it's a different group. It's extremely competitive to get in the integrated route. And it's a different tract, and the track is at least what I'm hearing, and the fellows I've trained, they tend to be a little better on the endo side than the fellows who go the traditional route, and a little lower skilled a little bit on the open. And then the fellows are different. They're a little better on the open since they did 5 years of general surgery, and a little less skilled on the endo. But I think then once they get out, I think it all molds together and is okay. I don't think that every integrated program can provide the open volume they need. But almost every fellowship program can provide that. So that it's really, you have to be really selective if you're going to do the integrated route. And I don't think you have to be as selective. Dawn, can you echo that, or you feel differently?
No, I think there are some things that you said that I really do agree with, but I do think there are some nuances. And I guess what I'll propose is this, is that I think that not all medical students know what vascular surgery is. And so I think there's always going to be a role for the integrated residency and for the fellowship. And I do think that kind of some of your comments about what the fellowship skill set might look like with that training, it rests on the presumption that the general surgery residents have had a lot of open exposure, either to vascular or not. But really what I've seen is that's really dependent on where trainees are going to practice for residency, what that open surgical training looks like, and then specifically how much vascular they're seeing. Because with the rise of endovascular and minimally invasive general surgery, I think kind of collectively general surgery residents have less exposure to open surgery than they ever did. And so I think that has changed the skill set that our fellows come with our program. I totally agree that the endovascular comfort level looks very different because our residents are exposed to it for 5 consecutive clinical years. And so for sure, I would say that's true. I think that when I look at our own program, and there are some nuances, again, not every integrated program or every fellowship is the same. I think you really need to kind of think about where you're going to find yourself in practice, what your goals are when you go to a training program. The integrated residents, do you want to go to a program that has dedicated time for academic development or professional development and kind of a lab experience or exposure? All of these things are really kind of nuanced. And so at the end of the day, there's a way to benchmark where programs are with specific types of cases. It's really pretty available data. And I can suggest that at our program, our residents and our fellows graduate with very similar numbers, both open and endo, because their training looks different. Our residents during their final 2 years have a training paradigm that essentially looks like a fellowship. And those first 3 years look very different. And so I can say with honesty that our 2 products, when they leave, are comparable. And we've heard feedback when they've gone on to obtain faculty positions that suggests to me that their effectiveness is comparable as well. And I do think that, the data that's kind of borne out is that our residents are leaving their programs extremely proficient and ready for practice. But in no way does that mean that brand new faculty transitioning into independent practice don't need kind of senior onboarding and mentoring. And I would encourage all of you, as you're kind of navigating these programs, think about what you need from a program, because they're all different. And it doesn't mean that kind of one program is going to be better than the other. They're just different. And so they'll meet different student needs. And then ultimately, once you finish, please know that everybody deserves to have kind of the support of a senior member of a group to help you navigate at least those first 6 to 12 months. Because I personally think even with a really robust training program and super high case volumes, you're going to get into independent practice. And there's something very daunting about that. And having a senior partner that you can leverage, who can be available to you to help with case planning or to bail you out or just be there to support you during those first few big cases, that's extremely relevant. And the folks that I've talked to that have struggled through their first faculty positions, it's mainly been because they've not had the support they need from either a dedicated mentor or their partners. And so really, again, I think that people make all the difference. And I don't think the training programs are the same. I do think they're mainly equivalent when you think about vascular surgery skill set acquisition, but I do think the phenotype of the trainees that are coming to us look very different, and residents and fellows by definition have different needs.
Great. Well, thanks, Dawn. Anil, endovascular techniques have certainly transformed the field of vascular surgery. What's sort of the next big step that vascular surgeons are going to take into their armamentarium? What's sort of the hot and things that are coming up?
That's part of the domain of research, and I think part of the research that's going on has actually been quite exciting. All three of the vascular surgeons here are actively involved with publishing and trying to progress the field. I do think endovascular is going to actually accelerate and continue to make more and more procedures that were open procedures and thought to be only open procedures. I think that's going to continue. Issues that we need to deal with in that process are looking at alternative techniques for imaging, such as ultrasound guidance. I think that has always been something we've been very interested in. Also, looking at radiation safety, I think, is also going to be an important component, and that's something that we are actually very interested in trying to establish national standards for radiation safety for all vascular practitioners, because if the endovascular revolution is going to be taking over more and more cases, we need to do it safely for ourselves and our patients and our staff.
Patrick or Dawn, you have any other thoughts on that?
I think what's interesting it's Pandora's box, so to speak, or no one wants to talk about, is the diversity in the ability to work as a vascular surgeon. So you can own a vascular lab. We're one of the few specialties that we actually interpret our own images, which is extremely nice and extremely helpful that we get to do that. Additionally, many vascular surgeons own their outpatient lab, and they do things in an outpatient setting. And so there's a whole different host of practice patterns, whether it's as the university type like I'm in, or whether you want private practice and own your own vascular lab / outpatient lab, and or work for a hospital. And I think that vascular surgery really has the ability to do some pretty neat things for bright minds who want to think a little differently. That some specialties don't have that option. It's hard to do open heart surgery in an outpatient lab or do some things like that. So I think it's food for thought. And sometimes the young minds are very interested in, wow, you can do that. These are options for you. And I can run a vein center, and then I can have a great life and still make a nice income. So those are, I think, very neat things that are somewhat specific to vascular surgery.
Great. And Dawn? Well, I love all of those comments. I echo everything that's just been said by Patrick and Anil. I guess maybe the one thing I'd add is that I guess to all the students listening, there's a tremendous amount of job security in our specialty right now. Like we really want you. We want to train more great vascular surgeons. And we have a growing aging workforce, a growing aging patient population. We also have a growing aging workforce, but we need to grow faster. And so I guess my point is really twofold. One, that I think you're going to meet a really nice reception, kind of open arms from most vascular surgeons who want to mentor you and want to share what it is about our specialty that we like so much. And I think you'll find a lot of enthusiasm out there, because I really do kind of deeply believe that most of us are very happy doing this job. And so take advantage of that and leverage that. I'd also suggest that for the folks that we're going to onboard and train and bring into our workforce, I think we have our work cut out for us, because with an aging population and really well-described healthcare disparities and access to care issues that many of our patients face, I think that's going to be an area for continued kind of study and emphasis in a way that not just considers helping individuals in specific areas where access to care is a problem. I think we also have to think about how we can leverage our collective healthcare resources to do the right thing for patients. And that may require some degree of collaboration with other specialties in the future. Hi. Okay. And so I think that I think we have our work cut out for us, and we all have to think really maybe creatively and a little differently than we have in the past, just to optimize the delivery of healthcare to those that need it most. And I do think that the rising generation, I think you all think differently. I actually think that there are some challenges that we have struggled with that you're going to help us kind of resolve in a way because of your problem solving capacity, maybe resting on different mental models than we've rested on for a long time. So super optimistic.
Great. Well, I hope we caught that video because your son did the classic Zoom bomb, and it's wonderful. Glad see that achieves the work-life integration that everybody wants to see. We have just a few minutes left, and I think one last question, especially in trying to pair cardiac surgery and vascular surgery up with this webinar, is how do you integrate yourselves with cardiac surgeons or the interventional radiologists, for instance? The one area that students may have some question is, okay, I want to just work on the thoracic aorta. So do I become a cardiac surgeon? Do I become a vascular surgeon? Do I go into radiology? Do I do cardiac and a vascular fellowship? And so, Anil, I don't know if you're still there, but could you answer that for us?
So as the endovascular revolution has been progressing, we've actually been doing more and more procedures, not just left of the subclavian, but now some new technologies that's coming out is actually reaching farther and farther into the chest. We actually take more of a collaborative approach. It's not either or with the cases in the chest. We tend to work with our cardiothoracic surgeons, be it endo or open. I think that actually offers a lot of strength to working together, because by working together, we are all stronger.
Great. Patrick?
I think one of the cool thing that we have here at Vanderbilt, we have a great collaboration with our cardiac surgery colleagues. And another point that I didn't mention earlier, that as the endovascular revolution started, it was a concern that we were going to lose some of these open vascular procedures, such as when I first started, we were doing carotid subclavian bypasses and transpositions, then we were stenting, and then they seemed to go away. And I was like, well, that's terrible. We lost those operations. But now with thoracic pathology, that now we're extending over the subclavian and or branch devices, and now we're going back to carotid subclavian transpositions for different pathology, for aneurysm disease, to make sure we keep flow to the left arm, et cetera. So I think it's neat how, as we've advanced endovascular, we've also had to bring back other open techniques. And I think that's a pretty exciting thing that to just emphasize to the young minds.
And Don, what do you think about, there was a question previously about double boarding. Should they do vascular and the cardiac fellowship, or?
Yeah, I had a medical student meet with me today, and they asked this exact question. And they also asked me what a cardiovascular surgeon was. And I think that's really interesting, because I think you're going to get kind of a few really specific visceral reactions depending on who you talk to. I'm part of a collaborative kind of cardiovascular centers. So we work really closely alongside our cardiac surgery partners and interventional radiology. We have less of an interventional cardiology footprint where I'm at, but that's just, our place, and it looks different at every institution. I'm all for teams. I think that diverse teams are going to deliver the most effective care. And I know that not every vascular surgeon or cardiac surgeon might agree with that, but I personally favor collaboration and leveraging skill sets. I think for the budding aortic enthusiasts who want to treat from the aortic valve down to the iliacs, I do know, a handful of individuals who do have combined vascular and cardiac training, and two of the fellows that I trained with at Michigan have that background. And I don't think that's wrong. I think it's a ton of training. It wasn't for me, although I really pride myself in being able to conduct, pretty substantial thoracoabdominal aortic interventions. And I used to put people on pump independently. And I chose not to kind of now in this present day for a variety of reasons. But I would just suggest to you every resident or fellow, every trainee is going to want a different type of practice or specialty. And, some people are going to want to have an aortic heavy training experience. And if that's what you want to do, then, go for it. But I think for the majority of kind of cardiac and vascular trainees out there, I see little added value in having joint training in that capacity, because I think you will have the opportunity to leverage experts and partners at your institution if you find yourself in the right setting. And I would say similarly, we have individuals that ask this question of trauma. And so vascular trauma specifically. And so it's a little bit different and nuanced, but kind of a similar training paradigm when people are considering whether or not they should do an integrated residency or a fellowship if they really want to have a heavy trauma practice. And some of our military surgeons ask that, with frequency. And so I don't think there's a right answer for any of these questions or a standardized recipe card for what makes a very successful product of training, but just be honest with what you're looking to accomplish during your tenure as a surgeon, what you want your practice to be like, and then just try to find the training program that's going to meet those needs, because there are a lot of really great training programs out there.